It is a moment of extreme pleasure to welcome all the guests who are here with us to join this workshop held in collaboration between Snibe Diagnostics and PSCP. We are truly honored with your presence. As per title of the workshop, we will learn on the topic of chemiluminescence, the queen of immunoassay. So we are here to update our knowledge, and we are here to learn the new techniques, the new parameters that are being introduced through this instrument.
Tumor markers have gained an important role in the cancer management. And in this regard, their use is now increasingly taken up by the clinicians and oncologists. For that reason, the main emphasis should be on the selection and appropriate methodology of performing the tumor marker.
You can't imagine how much the scientists have worked out to make this test possible. It passes through genetics, through metabolomics, and many processes until it is available. Can you name an instrument? All 4 tumor markers are available on one instrument. Maglumi. Let's have a clap for Maglumi then. Chemiluminescence assays are now available for a long list of tumor markers. Maglumi offers a very wide range of these tests available in Pakistan. There is a need to create awareness among clinical and laboratory specialists to understand the utility of these tests.
عالم الغيب والشهادة هو الرحمن الرحيم هو الله الذي لا إله إلا هو الملك القدوس السلام المؤمن المهيمن العزيز الجبار المتكبر سبحان الله عما يشركون هو الله الخالق البارئ المصور له الأسماء الحسنى يسبح له ما في السماوات والأرض وهو العزيز الحكيم صدق الله العظيم.
Jazakallah. I am Dr. Nusrat. I am Associate Professor Chemical Pathology, and I will be moderating this occasion. It's heartening to see so many familiar faces sitting in the audience. Some of you have traveled from other cities, some have even traveled from another country. So I would like everybody to give a round of applause for the audience. MashaAllah. Thank you so much. It is a moment of extreme pleasure to welcome all the guests who are here with us to join this workshop held in collaboration between Snibe Diagnostics and PSCP. We are truly honored with your presence. As per title of the workshop, we will learn on the topic of chemiluminescence, the queen of immunoassay. I feel honored and privileged to welcome our chief guest, Professor Brigadier Retired Abdus Sattar. He is the chief guest of this occasion. Right now, he is working as an HOD pathologist, CMH Medical and Dental College, Lahore. Today, I was asked to introduce him, and when I searched for his name, I realized that itne nafis, itne down-to-earth person, he's a Sitare Imtiaz for his services, in recognition of his services towards armed forces. That I think itself is a great honor, and not only that, he was given a Lifetime Achievement Award in Pathology in 2012. So we have a gem of a chemical pathologist among us who is a teacher of the teacher as well. He is a chief guest. Without further ado, we were supposed to wait for the tea, but tea is a bit late, so we will start our session with, should I start, Doctor? Okay. So, what are we here to learn? Some of us don't know anything about chemiluminescence. Some of us don't know anything about the autoanalyzer that is connected with it. So we are here to update our knowledge, and we are here to learn the new techniques, the new parameters that are being introduced through this instrument. So I hope this workshop enlightens us and provides us with the approaches to deal with the problems of tomorrow. So without further delay, I would like to invite Professor Dr. Asim Mumtaz, who does not need any introduction. He is currently working in Akhtar Saeed Medical and Dental College. He is a pioneer in establishing the Pakistan Society of Chemical Pathologists, and he is the most distinguished chemical pathologist that I was fortunate enough to work with. So let's welcome Dr. Asim. He will talk about smart use of traditional tumor markers. Round of applause, please.
नहीं ठीक है अस्सलाम वालेकुम Thank you very much, Dr. Nusrat, for introducing. Respected Dr. Sattar, Professor Amir Ijaz, Dr. Akif, and all the senior chemical pathologists who are sitting over here. It's an honor for me to present the topic in front of my senior colleagues also. The topic which has been selected is the smart use of the traditional tumor markers. Hopefully, I will try to summarize. Not all markers can be covered in this presentation, but major which we are using among the traditional markers I will cover up. Tumor markers have gained an important role in the cancer management. And in this regard, their use is now increasingly taken up by the clinicians and oncologists. For that reason, the main emphasis should be on the selection and appropriate methodology of performing the tumor markers. The brief outline of the talk will be based on the few facts about the historical background of tumor markers, types of the different tumor markers, the clinical applications, and what are the characteristics of a tumor marker, ideal tumor marker. Then, particularly the quality requirements for performing tumor markers, what they are, and what the guidelines are for the quality requirements. And then, few words about the different tumor markers. It's not a lengthy talk, don't be afraid. It's just to summarize the things. Tumor markers, they have gained so importance that different guidelines have been published by different international groups. And these groups have published the guidelines in which they have emphasized the appropriate use of the tumor markers. In just one sentence, we can summarize the definition. There are many definitions which are available in the books also. Tumor markers are the substances present in and produced by a tumor or by the host in response to a tumor. This is the simplest definition. Few facts about the historical background, how it started, why they were called tumor markers. In this regard, in 1847, Dr. Jones published an insightful discovery based on a urine specimen produced by a 45-year-old grocer and heat precipitated for the benzone protein. It was documented, and in the case of the multiple myeloma at that time, Dr. Jones developed the first biochemical cancer test, that is proteinuria detection in multiple myeloma. But it was more than 100 years before discovery of alpha-fetoprotein and carcinoembryonic antigen in 1963. If we just go through the chart, many markers, they came and faded away, and these are the all parameters which, with reference to the year, starting from the 1847 to 1985, multiple, they gained the importance because of the association with the malignancy. That was the major issue. Some are specific to some extent, some are specific to more extent, but until the development of the RIA, these were not in the routine clinical methodology. In 1950, around 1950s, the RIA, the forefather of all these amino acids, was established. And with the development of the RIA, then these tumor markers got the use in the clinical practice. That is the reason it took so long. All these parameters were performed by different techniques, but there was no unanimous or sensitive technique for which we could say that it is the right technique to perform the tumor markers. Gold and Freeman in 1965 isolated a glycoprotein molecule from the specimen of human colonic cancer and thus discovered the first tumor antigen, which was later identified as CEA, carcinoembryonic antigen. It has been used and it is still being used very. Just to apprise you, before pre-70 era, Benzone protein, LDH, prostatic acid phosphatase, beta-ICG and CEA were the markers which were used for diagnosis of the association with the malignancy or the diagnosis of other malignant conditions. At that time, immunochemical or enzymatic methods were used. They were all manual. During the decade of 1970 and 1980, the prostatic specific antigen CA125, ER and PR, they were invented and they were used by the RIA or immunometric methods. They were rather manual at that time. And then immunohistochemistry also was discovered and used for the clinical application and for the diagnostic facilities of the tumor markers. The number of publications on tumor markers in 1973 was 260 in Index Medicus, and it raised to 223,000 in 2015 in PubMed. It doesn't mean that tumor markers have become so special, but still there is a problem with the ideal tumor marker. There are different characteristics of the ideal tumor markers. Apart from this development in the research, and still it is going on, still you can see many articles regarding the tumor markers, but the actual tumor markers which can be solely used for the diagnosis of the cancer are still awaited. Sorry. Number of the tumor markers with established roles in clinical practice have remained rather slow, and still there is a need of the ideal tumor markers. Now the types of the different types of tumor markers, what they are. Enzymes, for example, prostatic acid phosphatase, alkaline phosphatase and neuron-specific enolase. These were the markers which were used for the different cancers like prostate cancer, then bone and variant ALP, which is used for the hepatocellular carcinoma, and then placental alkaline phosphatase. Then neuron-specific enolase was used for the neuroblastoma. Similarly, hormones like beta-ICG, calcitonin for thyroid carcinoma, and prolactin, either it is used for the benign, but still it is known as a marker. Like proteins, carbohydrate antigens like CA125, CA 15.3 and CA 19.9 in different cancer like ovarian cancer, then breast cancer, and then chronic cancer or pancreatic cancer. They are the markers which are being used till now. Alpha-fetoprotein and CA, they come under the heading of oncofetal antigens. And regarding the receptors, estrogen and the progesterone receptors and epidermal growth factors, they are now commonly used, and they are the mandatory part of the histopathology for the proper prognosis and the treatment of the breast cancer. The normal protein like thyroglobulin is also used for the thyroid cancer, but along with that, other modalities are very much compulsory for establishing the diagnosis of any malignancy. Solely we cannot depend on these markers only. The clinical applications of tumor markers, screening of the cancer, because they are not specific, so that they are not used for the routinely for the screening. But occult blood for the colorectal carcinoma can still be used, and it is being used at some, but not so commonly. For the diagnosis of the cancer, diagnostic aid के तौर पे ये help कर सकते हैं. Otherwise, complete diagnosis at their own, it cannot be taken on the basis of these values. Like alpha-fetoprotein in hepatocellular carcinoma, it is specific but not to the specificity which is required for an ideal tumor marker. And in differential diagnosis, like in a pelvic masses CA125, you have to differentiate between the benign and the malignant before doing the biopsy. Then it can be useful in that case as per their level. Then assessment of the prognosis of the cancer. And for the selection of the therapy, in this category, alpha-fetoprotein and beta-HCG are used for the germ cell tumors. Selection of the chemotherapy is also based, it helps in that one, not the purely other conditions, other patients' parameters are also considered for this chemotherapy. Now the prediction of the response, this is one of the good thing in ER-PR, that is the established role, has been very much clinically used by different histopathologists and for the oncologist, and these are the mandatory parameters now being performed. Then monitoring the response of the treatment. For the example, ovarian cancer, in that the level of the CA125 is serially monitored after the treatment. If level declines, then it means the treatment is successful. Then monitoring the disease or post-treatment to detect the progression or the recurrence of the disease. In that case, the CEA for the chronic cancer is used for assessment of the any recurrence. What is ideal tumor marker? In reality, it does not exist. But there are a few characteristics which can be labeled to the ideal tumor marker. It should be highly specific, meaning by that it should not be detectable in other tissues. It should be detectable only in one tumor type, but it is not the actual case in reality what we face. It should be highly sensitive, not detectable in physiological or benign disease state. Again, this is not the characteristics, the markers which we are using. Then levels correlate with the tumor burden. Then this is important because prognostic and the predictive utility of the tumor marker can be in case of the size of the tumor. Then short half-life in circulation. Frequent serial monitoring of the marker levels after 5 to 6 half-lives is useful in assessment of the prognosis or in assessment of the recurrence after the treatment. Then it should be cheap. In this category, there is no tumor marker apart from which is the occult blood, which is not considered as a marker, but it is sometimes being used for that one. Commonly requested, there are long list of the tumor markers. These are the traditional tumor markers. There is a long list of the novel tumor markers. I think it will be, I can't count, but it will be more than 100 tumor markers which are available. Rather, Dr. Professor Amir Ijaz will highlight more on that one, the now which have become more new inventions in that one. Alpha fetoprotein, prostate specific antigen, cancer antigen like CA125, CEA, human chorionic gonadotrophin, and CA19-9, and then calcitonin. These are the commonly requested, and we see the request off and on daily basis coming to our labs or your labs. You must be seeing that. First of all, prostate specific antigen. Total prostate level in the body is less than 4 nanogram per ml. Now these are the reference ranges which are given by the inserts. These have not been established in our population. It is in two forms. One is the bound, second is the free. The bound form is with the alpha-1 anti-chymotrypsin. It is up to 70 to 90% of the total bound one, total PSA level. Then its half-life is 3 to 4 days. The free form is about 10 to 30% and the half-life is 2.5 hours. Then second category in this level is, in this marker is the PSA velocity. The range of the rate of the change over time after the treatment or before the treatment, or first when it is diagnosed that the patient above 65 years they are having. The serial monitoring of this marker can be helpful for the early detection of the prostate cancer along with the ultrasound. Then there is a term which is now used, that is the PSA density, which is estimated by the dividing the serum PSA in microgram per liter by the prostate volume in cc, which is measured by the transrectal ultrasound. It is used for the assessment of the early detection of the prostate cancer. Free PSA and total PSA measurements using paired kits from the same supplier should be used. This is more important. If we are using some other kit, it may not be helpful. Diagnostic gray zone is 4 to 10. Ideally, it should be less than 1. But if it is lies, if a patient is more than 65 years, then he should be checked serially. Some recommend the serial monitoring should be after 6 months, some recommend after 3 months, and if the age is less, then if it is in the gray zone, they recommend after on yearly basis. Now, second thing is the free to total ratio, which is important. Ratio is lower in prostate cancer patients, and it is very easy to measure it. Free is available in the market and in different instruments, it can be used. There is a study which has shown that men with percentage of the free PSA level, less than 10%, have a greater chance, more than 50% probability of prostate cancer. And those men with greater than 25% of the free PSA have a less than 10% chance of having the prostate cancer. Even then, ultrasound and other markers are also necessary for the diagnosis of this one. Now, the free PSA testing can reduce the need for 20% of unnecessary biopsies. If the range is within the gray zone, then oncologist or the surgeon can go for the biopsy, but free PSA testing has reduced this percentage of the unnecessary biopsy, which is an invasive procedure. Few words about the alpha fetoprotein. It is an oncofetal antigen, and in hepatocellular and germ cell tumor, it is used as a marker, and its use in the hepatocellular carcinoma is very common, but it is not specific. It is raised in other conditions like chronic liver disease, pregnancy, in which it is appropriately increased. In other conditions, it is inappropriately increased beyond the multiple of the reference limit. Alpha fetoprotein and beta HCG combined are useful in classifying and staging germ cell tumors, one or both markers are increased in those tumors. In hepatocellular carcinoma, the ultrasound is also very important, plays important role. Regarding the diagnosis of the hepatocellular carcinoma, alpha fetoprotein for more than 1000 often increased in cancer. Can detect 50% of the hepatocellular carcinoma at this cutoff. Again, there is requirement of the other modalities. Alpha fetoprotein of 500 nanogram per ml plus ultrasound and biopsy is necessary for that one. Screening is done only for high-risk population or countries like China, Africa and Japan, Alaska, where its prevalence is more. The prevalence factor is more to be considered when we are doing the screening. If the prevalence is low, there is no use of the screening for these parameters. Serial levels of the alpha fetoprotein then single level can more actually identify those patients with HCV and advanced fibrosis and cirrhosis who are most likely to develop the hepatocellular carcinoma. Use of the alpha fetoprotein screening applied to its uses as an aid to diagnosis, whereas its measurement in conjunction with ultrasound may aid in the early detection, but not the diagnosis. Regarding tumor markers, some broad principle applied to the laboratory professionals and laboratory medicine with more emphasis on selection and appropriate use of the tumor marker. Secondly, methodological issues relating to the tumor marker, which is very important in selection of the method. Then interpretation and reporting of the tumor marker. All these parameters are like those which we are performing in the routine chemistry. But we have to pay more emphasis on these parameters in terms of the tumor marker, because any erroneous results can cause more panic to the patient if we compare it with the routine chemistry or routine parameters. Internal and external quality control is very important for running these tumor markers in your setup or in any setup. Pre-analytical requirements are the same as it is for the routine samples. There should not be any hemolysis. The sample handling is very important, and the specimen type is also very important, which is given in all the inserts, but it should be in the mind of the pathologist or the lab managers who are working with you. Analytical requirements. Assay standardization, that is very important. We have to standardize the method. Already established method should be used, and the technique should be the more sensitive and more specific as compared to the less specific or less sensitive technique. The sensitivity matters a lot in this category of the markers. Running of the internal and the external quality control program is very important. I was just checking about these tumor markers quality assurance program external. If we apply for the 55 parameters, it's just the expense of about the sera which we get from outside. It's about 800 rupees per month, which is not a big deal though for those labs who are there. Recommendations are different for different markers, but it should be low, and the normal or pathological must be used. Interferences must be kept in mind when we are performing these parameters, like endogenous antibodies. There are multiple types of the antibodies which can interfere with the different techniques. The post-analytical requirements, they are reference intervals. If we are doing with one method, the reference interval is different, and if we are doing other lab is doing with the other method, he may report the reference interval with other range, and it may cause problem to the patient. So when it is reported, it should be kept in mind that the reference and interval should be same in our lot, because we should not change the method so frequently if there is any problem with that, unless. These are the guidelines which have been published. You can get it from the internet. These are National Academy of Clinical Biochemistry, use of the tumor markers in clinical practice, quality requirements. All these requirements they have documented in detail, only for the tumor markers. There are different methods which are in use. The forefather of the radioimmunoassay, which was first used for the insulin in 1960, and then for other markers like oncofetal antigens, like ELISA, chemiluminescence, and electrochemiluminescence. But chemiluminescence and electrochemiluminescence, they are more important because the sensitivity is far better than the other techniques. The interferences, they are relatively less than the other techniques. Care should be taken when interpreting the low results, particularly for the analytes such as the tumor markers that can have very high circulating concentrations. Because we have reported alpha fetoprotein up to 10,000. That is important to report. Oncologists demand for that one because of the monitoring of the treatment. But if we just give the report more than 1,000 every time, and the level is, you are not giving the exact level, it will be problem for the oncologist, because there is no other way. Advantages of the chemiluminescence method is it's highly sensitive and more specific, linearity range is more, wide dynamic range available in this instrument, Meglumi. Then it's a random access, and auto dilution option is available in this one. Linearity range is one of the factors which is covered in this one with the auto dilution 1 in 10, 1 in 20, and 1 in 50. It's your discretion, whatever you can choose. This is brief data of alpha fetoprotein on Meglumi. Total number of cases in 6 months, we performed about 460. 218, they had the range of 0.5 to 15.7, and 160 patients had the level of 50 to 600. Then 82 patients had 800 to 10,000 level. Now in this category, the important thing is to highlight is that the 800 to 10,000, the patients which are getting these values, they should be serially checked. And the capacity of the instrument is more than 1,000, so dilution is important in this particular marker. Similarly, in case of prostate-specific antigen, ideally it should be less than 4, but if it is between the 4 and 10, then it is within the gray zone. Number of cases which we received during the last 6 months, that is the 312, 209 were 0.01, and its sensitivity you can see 0.01 and up to 4. Then 38 patients had between in the gray zone. In 35, 12 to 36.7. Then 30 had the level of clearly 38 point up to 400. Now what we did, the only thing is that the communication. With particularly the cases which are, these are the second row and the third row, they need communication with the oncologist, because you have to report what result is there, but communication is more important. What are the other findings? So that patient should not get the erroneous report or anything wrong. We must check it again. If the oncologist is not satisfied, if even our external and the internal quality control are well within the limits, we must have the communication with the oncologist or the surgeon regarding these parameters. The key points: carefully used tumor markers can contribute usefully to the patient management, but awareness of their limitations is essential for the laboratory professional. Serial results are nearly always more useful than single isolated result because main application of the tumor marker is in monitoring. It's not in the diagnosis. Specific and sensitive methodology like chemiluminescence must be used for the measurement of use of the internal quality control, and EQS schemes for tumor marker must be the policy of the lab. Ideally, results obtained in different methods would be fully interchangeable, but data from the proficiency testing schemes confirm that this is not the case. Between method CV in excess of 20% still observed in some tumor markers. This is very important. In proficiency testing schemes, data which have been published that they show the different methods CV is different, so we must be very careful. The last point is excellent communication between the clinical and the laboratory professional is essential for optimal use of the tumor markers. Thank you very much.
Thank you, Dr. Asim. The key point at the end of his presentation, the communication between the pathologist and the clinician is of utmost importance in these parameters. Now I would like to invite our second speaker, Brigadier Retired Amir Ejaz. He's a teacher of the teachers, and right now he's working in Mohyuddin Medical College, Mirpur, Azad, Kashmir. His contribution to the field of chemical pathology is exemplary. He has nearly 160 publications and authorship of 6 books and book chapters. And his keen interest is in the pediatric metabolic disorders and also in medical education. Without further ado, I would like to invite him. His topic is novel tumor markers assayed on a chemiluminescence.
Thank you very much, organizers from Snibe, Mr. Tokir Bhatt and other people, and our Chinese friend is also here. And I'm also thankful to the audience for sparing their time on this weekend. I'm especially thankful to my teacher, Professor Brigadier Abdul Sattar, who has spared his time to come here, and my dear friend, Professor Asim Mumtaz. He has really delivered a beautiful talk on tumor markers. It was such a scholarly talk, I don't think I can do justice after his talk. Please, my presentation. The science of medical science is rapidly progressing. Every day you see new drugs, new tests coming out, and but when a test comes available to the clinical laboratories, it has gone through a long process of research. You can't imagine how much the scientists have worked out to make this test possible. It passes through genetics, through metabolomics, and many, many processes until it is available. I have chosen this topic of telling you what is going on in the field of tumor markers. What are some new markers? You might have heard some of them, but might not have heard most of them. And I won't say that all of them are very useful, but at least you should have some word about them. What they say these days, you must be sensitized about them. So that when you go outside the country or you meet some foreigners, you should have a bit knowledge of those particular tumor markers. I will take a lot of brand name. Especially I will take the name of Maglumi because I'm a user of it. So it is just the purpose is to create awareness. Many new emerging tumor markers are used in clinical oncology, increasing our knowledge about these markers regarding capabilities, limitations, and effective use is very useful. And this is to keep ourselves abreast with the ongoing process of research and development in the medical field. There is wide range of application of chemiluminescence. As you know, the theme of the series of these workshops or seminars is chemiluminescence, the queen of amino acids. Because as Professor Asim very rightly told us, that this queen has got very good sensitivity, and it is now fully automated. So why we call it queen? Because of its lot of characteristics. But I want to draw your attention towards another exciting aspect of this queen of amino acids, and that is very wide range. You can find hormones being done on it. Tumor markers is our today's topic. Metabolic disorders, autoimmune disorders, acute phase reactions, infections, drug testing, and many others. So each of these groups, and there are many other groups also, you can hold a full-fledged seminar, one-day seminar on each of these groups. So it has got very wide range. And the wonderful thing today is, if you see this chart, unfortunately this is hidden chart, this is the miraculous chart here. You will, if you see the list of tests being done on this instrument, this is marvelous. I'm saying it from my heart. You read, because if you are not in the medical profession, you may not understand what is written on it. But the doctor, the technologist, or anyone who is related to medical profession can very much see what is the meaning of these abbreviations written on the menu of this instrument. I'll today pick up only the tumor markers of this list, and you can then verify this list on this chart. So what are the chemiluminescence based analyzers available? Of course, Meglumi from our brother country China, and let me take this liberty to say these our brothers have done marvelous progress in all fields of life, but in particularly we can confidently say in our own field, pathology laboratory, they have done wonders really. As you go deeper in this technology, you really get astonished how much progress they have made. They are now ahead of many of their counterparts from West. And we are lucky that they are very much approachable, and we can get these instruments at any far-flung area also. So, but there are also other instruments, Architect from Abbott, Cobas by Roche, Advia by Siemens, Access2 by Beckman Coulter. They are also very good instruments. I am not talking against any of them. But the main advantage of this Meglumi of Snibe is very wide range. I will, in a few minutes, when I will tell you how wide this range is, you will really be astonished. So be pleased with me for about 20 minutes. So Meglumi has the widest range of amino acid based tests. Some parameters, first time in Pakistan, and some tests are previously done by photo. Have you heard of CKMB being done on an amino acid? We always heard that CKMB is done on the calorimetry, but they have introduced a chemiluminescence based method of CKMB. How good this method would be! Only a pathologist or a laboratory person can realize this thing. If CKMB is done on chemiluminescence, how good test it would be. Similarly, many other tests which were traditionally done calorimetry, they have put it on the chemiluminescence. So initial method of estimation, Professor Asim very nicely elaborated on them. I will not go, but I will support what he has said, that these methods should not be used for tumor marker. These ELISA, fluorescence, market is flooded with FIA-based instrument, small instrument, which is fluorescence-based instrument. I will not take commercial names, you all understand it. They are usually very small instruments. But why? Why we say tumor markers should not be done? I'm sorry, ye mic thoda sa zyada. Why? Professor Asim has told we should not use it. But why? Why we are doing it particularly for tumor marker? I will ask one question from you. Is doing tumor marker an emergency? Is there any situation when PSA is required within 1 hour? Alpha beta is required in 1 hour, 2 hours? Any CA is required in 3 hours? No. You can wait for 24 hours. So what is the advantage of using smaller instrument just to increase the turnaround time? No advantage. Second and more important thing, this is the question of life and death. You are declaring someone free of cancer. You are declaring someone having a cancer. So it should be done on a very, very good system, on a very accurate, sensitive instrument. So please don't do tumor markers other than chemiluminescence. Just do it on chemiluminescence. You may use any instrument, but do it on chemiluminescence. Otherwise, don't do it, because you will be giving wrong information. Not only in diagnosis, in monitoring also. For example, you give a false negative report or to a patient of cancer, and after 1 year, the cancer is found to be metastasized in the lungs and in the brain and liver. Who is to be blamed? That particular laboratory who has done the tumor marker on smaller FIA instrument. So please use a chemiluminescence system. Professor Asim has already talked about PSA and free PSA. I just wanted to add that a very specific and sensitive marker, and he said that PSA and free PSA should be from the same instrument, same company, same instrument. Only then you can get that ratio useful. And according to my knowledge, the Maglumi offers both these total PSA and free PSA in the same instrument. So you can very easily do it in the same instruments. There is another test which is quite old, which is prostate acid phosphatase, but there are new applications to that PAP. Now it is being used for the castration-resistant prostatic cancer. There is a technical detail of what is castrate-resistant prostatic cancer, but PAP can be a good marker for that. So he has already talked about it, so I will not go in detail. Now there is another question, now again from my younger colleagues. I am in very bad habit of asking questions. My students know it. So the question is, tumor markers are more important in which of the following tumors? कौन से कैंसर में ट्यूमर मार्कर ज़्यादा इंपॉर्टेंट है? ब्रेस्ट कार्सिनोमा, ओवेरियन कार्सिनोमा, दो चॉइस है आपके पास. किस में ट्यूमर मार्कर ज़्यादा? जो पहला करेक्ट आंसर आएगा ना, उसको मैं क्या दूंगा? मेरे पास और कुछ नहीं है इस वक्त, चॉकलेट ही दे दो. ओवेरियन. और बोलते जाएं, हो सकता है कि सही हो गलत हो. यंग लोग बताएं ना. ब्रेस्ट. और बोलते रहें. जी सर, आपने सर यू आर दी फर्स्ट वन. आपने ओवेरियन क्यों कहा? नहीं, ओवेरियन क्यों कहा कि उसमें ज़्यादा इंपॉर्टेंट है? यू आर राइट, ही इज़ राइट. इट इज़ मोर इंपॉर्टेंट इन ओवेरियन, नॉट इन ब्रेस्ट कैंसर. Very common sense reason, very common. The breast cancer, yes, madam. Visibility है वो तो फौरन नज़र आ जाएगा. Ovarian cancer is notorious for its hiddenness. ये छुपा हुआ कैंसर होता है, ये नहीं मिलता आपको. एक छोटा सा वाक़या मैं आपको सुनाऊं. मेरे एक रिलेटिव थे अमेरिका में जो मल्टी मिलियनर थे, जूट का कारोबार करते थे उस ज़माने में, और वो बिलियनर थे. वो हर साल अपनी बेगम के पूरा थॉरो टेस्ट करते, थाउजेंड्स ऑफ डॉलर्स दे के पूरी बॉडी की वो टेस्ट करवाते थे, कोई बीमारी तो नहीं है. वो करवाया और उनकी वाइफ विद इन 2 years ओवेरियन कैंसर से बहुत हो गई, डाइड ऑफ ओवेरियन कैंसर. इट वॉज नॉट डिटेक्टेड. इतने पैसे खर्च करके भी नहीं डिटेक्ट हुआ. सो इट इज़ नोटोरियसली हिडन कैंसर. So remember this thing. Tumor markers are of utmost importance in ovarian cancer, and at the same time, I tell you, they are least important in breast cancer. This is a viva question. They are least important in breast cancer, and they are very much important in ovarian cancer. Ovarian malignancy notorious for being hidden, appearing only in advanced forms. Serum tumor markers very useful. छुपा होते हैं, आपको नज़र नहीं आते होंगे, ठीक है. और कुछ सिम्टम भी ऐसी हैं, बड़ी वेग सी सिम्टम होती हैं, ख़वातीन इग्नोर करती रहती हैं, उसके साथ चलती रहती हैं. और जो द कॉमनेस्ट मार्कर इज CA125, and there is another marker. You might not have heard about this. It is called human epididymis 4 or HE4. It's a relatively new marker. There is a very interesting story how it was discovered. It was discovered retrospectively. First, its genetics was discovered, overexpression of genes, and then they found the proteins. I can elaborate on it if somebody wants during the dinner. But remember, HE4 is an excellent marker for ovarian cancer. And Maglumi offers both of them. Isn't it a wonderful thing that HE4 along with CA125 is available on this instrument? CA125, you all know, they are especially non-mucinous tumors. In 80% non-mucinous tumors, it is useful, but in mucinous tumor it is not very good. So best uses as like other tumor markers in the monitoring of the cancer, for detecting residual disease, for detection of recurrent metastasis, but there are limitations also. There are germ cell tumors and alpha-fetoprotein, beta-ICG, Professor Asim mentioned it, and inhibin. They are separate story. These germ cell tumors, they are quite different from other mucinous tumors, and these are the markers for them. Now, a very important situation is adnexal mass in the right iliac fossa or mass in the left iliac fossa. This is called adnexal mass. Adnexal mass gives a very important or the clinical problem to the clinician and what it is actually. So, for this question, algorithms have been developed, and mainly we use CA125, HE4, and menopausal status. Now, as I told you, we have to be very, very careful, very studious about digging the hidden tumor in the ovaries, and we have got only 2-3 tumor markers. Now, world over, there are different strategies which are used for, there are numbers actually, for assigning a risk of ovarian cancer to the patients. And there are very famous 4 strategies. One is called risk of malignancy index, RMI. The other is risk of ovarian malignancy algorithm, ROMA, OVA1 test, and OVA-SURE test. Out of these, OVA1, let me tell you, OVA1 test is a proprietary test of Quest laboratory. You know Quest, there are hundreds of laboratories in America and Europe, which is owned by one company, which is Quest. and over 1 is their priority. But there are other algorithms which are used by in United Kingdom and other areas. Roma has 3 components: CA125, HE4, and menopausal status of the woman. So, by assigning certain score to these 3 components, they assign whether the patient is likely to have an ovarian cancer or not. Similarly, Roma has different parameters. OVA 1, as I told you, has 5 amino acids. One is CA125, prealbumin, apolipoprotein A1, transferrin, beta 2 microglobulin. Beta 2 microglobulin is available on meglumi. Okay, ji. Now we are done with these CA ovaries. The next question is, can you name a cancer in which tumor markers are done before diagnostic or biopsy? We were just discussing that tumor markers are very useful once diagnosis has already been done, and they are useful for monitoring. But I give you challenge that in one cancer, tumor marker are used before biopsy, before the final diagnosis. To that extent, that the biopsy is not done until the tumor markers show some positive results. Can you name that tumor? No, not prostate. Any other? Youngsters, खाना नहीं खाया, भूख लगी हुई है. मेरे से जान उसे छूटेगी जो मेरे क्वेश्चन का जवाब दो. प्लीज. चलिए ये बताएं मुझे, कौन सा ऑर्गन बॉडी का जिसमें बायोप्सी करनी बहुत, पेंक्रियास भी है लेकिन और कोई? लंग्स की बायोप्सी करना आसान काम है? बहुत मुश्किल काम. It's self and procedure, very invasive procedure. So for lung cancer you have to first do the tumor markers, and if they are show some sign, only then you decide whether to go for biopsy or not. And what are the tumor markers for lung cancer? CYFRA 21. You must not have heard of CYFRA. Then neuron-specific enolase. This is a tumor marker for neural tumors also, and also for lung tumors. Progestin-releasing peptide, pro-GRP. Tissue polypeptide antigen. Can you name an instrument? All 4 tumor markers are available on one instrument. Meglumi. Let's have a clap for meglumi then. Okay. It's really wonderful. I'm sorry, मैं बहुत ज़्यादा ब्रांड नाम ले रहा हूँ, लेकिन मैं एस्टॉनिश होता हूँ रियली कि ये नाम आपने सुने हैं कभी, और ये मैग्लूमी पे अवेलेबल हैं. ठीक है, और ये दे आर अवेलेबल ऑन मैग्लूमी, एंड यू कैन, इफ अब जो यहाँ पे बिजनेस वाले लोग बैठे हैं लेबॉर्ट्री बिजनेस में, जिनकी अपनी लेबॉर्ट्रीज हैं या वो मैनेजर्स हैं, you know, if you are doing a rare test in your laboratory, you will attract more routine tests. You may have some bad business when you start a new test, but ultimately that new test attracts a lot of routine tests. So if you offer these 4 tests for lung cancer and do some publicity also, do some awareness also, I can tell you your business will flourish a lot. So this is the laboratory business. But for academic purposes also, please remember these. Please do go through in detail. I can't tell you in detail what these markers are. Especially they are for the non-small cell lung cancers. There must be histopathologists in the gathering, and they will be more familiar with this. Non-small lung cancers, they are very important, and early diagnosis of these cancers can be done with these tumor markers. The reference tumor marker for NSLSE are carcinomatomic embryonic antigen and CYFRA 21. The exact name is cytokeratin, cytokeratin fragment antigen. Cytokeratin fragment antigen is the real name, and squamous cell carcinoma antigen, the third one. And they are available on Meglomi. Other tumor markers, CA125, again for lung cancer, not only for ovarian cancer, but also for lung cancer. 15.3 is a marker for breast cancer, but also for lung cancer. 19.9, 72.4, and can you name an instrument where all these four are available? This one, our friend, Magnum. So I think it's quite a remarkable thing. These are the tumor markers of pancreatic. Yes, you were right. Pancreatic tumors are also notorious for being certain. But usually pancreatic tumors, they come out very early because of the abdominal pain, because of the symptoms. Secondly, its surgery is usually very, very tricky. CA242, CA50. These are the three carbohydrate antigens for pancreatic tumors and CEA, and all are available on Meglomi. So you might not have heard these antigens, these tumor markers, but they are available in Pakistan. Breast cancer, CA15-3 is the relatively common used, but I tell you, the literature says very few indication of CA15-3. Okay? So as I told earlier, breast cancer is one of those cancers where tumor markers are not very great, except one, HER2. HER2 has got one very important application, and the wonderful thing is HER2 is now available on the serum. Previously, it was only done in the breast tissue. So you can't repeat it. You can do it only once when you have removed the breast. But if it is available on the serum, it's a very good marker. And can anybody tell me what wonderful thing HER2 has to offer for patient of CA breast? Herceptin treatment. Dr. Rama, excellent. Herceptin. So this one tumor marker has got clinical, great clinical application. And Meglomi offers HER2 in the serum. I've seen it for the first time, HER2 being done in the serum. Previously, only tissue markers were available. So, now when it is available in the serum, you can do it daily even. If the patient is taking Herceptin, you can do monitoring, you can change your decision, you can adjust the doses, etc., etc. Some oncologists can some more light on this, the use of this, but I can't tell more than that. Similarly, for hepatocellular carcinoma, there is one excellent, wonderful tumor marker I'm going to tell you for the first time, and that is PIVKA. PIVKA is again an excellent thing. Along with alpha-fetoprotein, PIVKA is coming up very fast. What is PIVKA? PIVKA is protein induced by vitamin K antagonist. Very interesting name. This is a protein. If you if there is a deficiency of vitamin K in a patient, then this protein is induced. So by research, they have found this protein. This is a protein which is found when there is a deficiency or absence of vitamin K. So it is called protein induced by vitamin K antagonist 2 or deficiency. Both things are available. And PIVKA is again available on Meglomi. This is very wonderful, that PIVKA is available for you. If you offer these two, alpha-fetoprotein and PIVKA, for the patient of hepatocellular carcinoma, you will be doing a great job to your patients. Alpha-fetoprotein is very elaborately discussed by Professor Asim, and I will not go in detail. PIVKA is induced by vitamin K antagonist. also known as an abnormal form of prothrombin. It is actually an abnormal form of prothrombin. PIVCA is an effective tumor marker for hepatocellular carcinoma, has been widely used in the Western countries where most cases are hepatitis C. So, for hepatitis C, its role is well established in the West, but not for hepatitis B. But recently, Chinese studies have shown that it is also can be used for hepatitis B carcinoma. So my last slide is, chemiluminescence assays are now available for a long list of tumor markers. Meglumi offers a very wide range of these tests available in Pakistan. There is a need to create awareness among clinical and laboratory specialists to understand the utility of these tests. So these are available now. It is our job. If clinicians don't know this about these new tumor markers, it is our fault. We have to tell them. You know, pathologists, technologists, they are the brain of medicine. जैसे मैं रिटायर्ड फौजी हूँ तो मुझे एक यूज़ करने दें, जीएचक्यू में एक डायरेक्टरेट होता है, उसको एमओ डायरेक्टरेट कहते हैं, मिलिट्री ऑपरेशन डायरेक्टरेट। जितनी लड़ाई होती है, जो वॉर होती है, जो वो सब एमओ डायरेक्टरेट करता है। सर बैठे हैं इधर पर, तो जो जनरल एमओ डायरेक्टरेट को हेड करता है वो अल्टीमेटली बहुत ऊपर जाता है और वो सबसे बेस्ट। ऐसे ही नहीं सर, इवन उधर तो मेजर भी सबसे सिलेक्टेड होता है और वो पूरी रात काम करते हैं। तो मैं कहता हूँ पैथोलॉजी लेबॉर्ट्री इन हॉस्पिटल इज़ एमओ डायरेक्टरेट। वो सारी थिंकिंग सब जो है उसका थिंक टैंक वो पैथोलॉजी लेबॉर्ट्री है। सो यू पीपल हैव टू क्रिएट अवेयरनेस to your clinical colleagues, to your nursing colleagues about these new tumor markers. Only then they will use it. वरना तो वो उसी में रहेंगे, पुराने उस पर चलते रहेंगे और वो छोटे छोटे इंस्ट्रूमेंट रखे होंगे. Don't use those small instruments, at least for tumor markers. Thank you very much for patience.
Thank you, Dr. Amir. As a moderator, I have a very difficult task of preventing the people from going for dinner, I think, because they serve the dinner and we still have a very enlightening presentation by Ms. Fatma. She's a quality control manager at Ghurki Hospital, and she will be giving a brief overview of her experience with Meglumi, and I requested her to make it brief so that we can move the program a little bit faster.
As my topic of presentation is user experience with Meglumi 800, I have an introduction with Ghurki Hospital. Ghurki Hospital is a tertiary care hospital having capacity of about 700 beds. Ghurki Hospital is a pioneer of internationally recognized first spine center. Recently, the Ghurki Hospital has opened its door for the cancer patient by introducing the CyberKnife robotic radiosurgery. CyberKnife robotic radiosurgery system is an advanced technique for the treatment of cancers and non-cancer patients. It is the very first in Punjab and second in Pakistan, and this is the very successful ratio of CyberKnife robotic radiosurgery system is 99%. Ghurki Hospital has a modern diagnostic lab having all the sections of pathology. Our lab is equipped with the state-of-the-art, high-tech equipments. And Ghurki Hospital Blood Bank is licensed with the Punjab Blood Transfusion Authority, and we are performing more than 100 cross-match per day. For the screening of the patients, we are using Meglumi 800. For the screening, we are using Meglumi 800, that is hepatitis B, HIV, syphilis. Meglumi 800 is a member of Meglumi series, a fully automated chemiluminescence immunoassay analyzer. some general specifications. Maglumi 800 has throughput of 180 tests per hour, 240 qubits on board, and 40 sample position and 181 parameters that can be performed on Maglumi 800. General specification, easy operation, fully automated, high throughput, and the most important thing, that is cost efficient and user friendly. Some functional modules: pipetter, automated qubit loader, 40 sample position, mirroring chamber, washer, 9 reagent positions. Up to 40 reaction modules, 240 tests. The sample area is refrigerated, so the cooling function ensures the stability. There are the 40 sample positions and we can load the samples continuously. Reagent area is refrigerated, so the cooling functions ensures the stability of the reagents. 9 reagents on board with continuous loading function. And RFID technology. Maglumi kits uses the RFID technology. There is a sensor in reagent area through which we can read this. It can read this information on the reagents and send information to the software. The pipetter, it has the flexible reagent and sample arm. The sample needle is Teflon coated, which makes it the touch proof, and it is titanium made. It has the function of flow detection and liquid level detection and internal and external washing. As we already know, the Maglumi 800 uses the technology of chemiluminescence, that is known in enzyme involved flash chemiluminescence. AVI labeled stable in acid and alkaline solution. Nanomagnetic microbead separation, fast and efficient. Operational software. Maglumi 800 has a very user-friendly interface. It has an intelligent alarm function, so we can easily monitor the status of reagents and consumables. It provides us the very smart maintenance guidance, that is daily, weekly, and monthly maintenance guidance. The schedule provided, but that is very easy to monitor it. And we can run the third-party control on it, and the software provides us the Westcard rules and leviationing charts. Bidirectional LIS connection, TCP through TCP, IP, or COM. Reagent performance. Maglumi 800 provides us the reagent that is ready to use, no pre-treatment required. Each reagent includes the calibrators, RFID technology, RFID tag with built-in master curve, and 2-point calibration to adjust the master curve, and the reagent stability is maximum 4 weeks. This is the total menu that these are the parameters that we are performing on Maglumi 800 in Gurki Hospital. The thyroid profile, anemia profile, fertility, bone metabolism, tumor marker, cardiac profile, and infectious diseases. And this is the broadest CLIA test menu. These are the 181 parameters and 20 categories available in Maglumi. So Maglumi 800 is very easy operation, has very easy operation and system maintenance, interactive interface by smart laptop. And the Maglumi, the Snibe team is very cooperative, good communication, and they are providing us the best backup services. Thank you so much.
Thank you so much. Now I would like to invite Mr. Salman Shehzad, Sales Manager and Representative of Snibe. He'll enlighten us with the introduction of Snibe and Maglumi 3. Mr. Salman.
Hello.
Hello. Much waited, huh?
Yes.
Come.
Assalamu alaikum and good evening everyone.
My name is Salman Shahzad and I'm working with the Snibe Diagnostic as a sales manager for the Central Region Punjab. Before to start my presentation, I would like to say special thanks to our honorable guest for sparing their time and joining us. I will try to introduce the Snibe Diagnostic into the 4 aspects. One is the company profile, second one is the product portfolio, and the third is the technical details of our newly launched Maglumi X3 equipment. The fourth one is the quality management. This is the Snibe facilities. In our left picture, this is the headquarters of the Snibe Diagnostic, and on the right side, this is the R&D and the production center of the equipment and the kits as well. Shenzhen New Biomedical Engineering Company Limited. This is the global presence. We have installed more than 22,000 equipments over 147 countries.
They can't hear you properly. Use this one.
Okay. We have installed the 22,000 units over 147 countries. You can well appreciate from the picture, our 42% business is from the America and from the Europe. So Snibe is demonstrating the power of innovation and the marketing. Snibe was established in the 1995, and in 2010 we have launched the first Maglumi fully automated Kalaya instruments. In 2018 we have launched the first fully automated fastest Kalaya equipment Maglumi X8 with the 600 tests per hour throughput, and you can attach the 3 more equipment with this. And you can enhance the throughput of the 2400 tests per hour. In 2020, we are listed on the Shenzhen Stock Exchange, and in 2021, we have launched the molecular and the diagnostic products as well. This is the Snibe Instrument Manufacturing Center. We have an ability to produce the 3,000 equipment of the special chemistry analyzers annually and 1,500 units of the autochemistry analyzers annually. This is the Regent Manufacturing Center. We have an ability and we are the more top 10,000 grade clean working bench for Regent production, and we have an ability to produce almost 1.5 million kits every year. We have the several models to meet the customer requirements and the market demand in our product portfolio. We have accurately identified the end user's pains, the large daily test demand. Yes, we have the high throughput equipment like Maglumi X3, like Maglumi X8, poor stability of result in terms of the high pack sizes of the kits. Yes, we have the high performance equipments with the low pack sizes of the kits with the 50 test pack size of the kit and the 100 test pack size of the kit. The crowded lab space, yes, we have no issue. We have instruments which are covering the lab space and produce the maximum output. High instrument failure rate, we have the high reliable instruments. High regions consumable cost, we are the cost efficient because our calibrator and the control are the part of the kit, and you don't need to purchase the calibrator and the control separately. Complicated manual operation, we have a software which is very user friendly. Lack of special parameter, we have the comprehensive test menu over 181 parameter which can cover the 20 disease panels. This is our business segments in Kalaya instruments. We have the Maglumi 800 instrument is the benchtop model. We have the Maglumi 2000 equipment is the benchtop model. Maglumi 2000 plus and the Maglumi 4000 is the floor mounted equipment as well. And the Maglumi X8 is the higher in the throughput, is the 600 tests per hour throughput, and the Maglumi X3 is the 200 tests per hour throughput. We have also the biochemistry and the electrolyte analyzer, Biosys 240 and the Biosys A6. Also we have the Biosys C8 analyzers of protein chemistry. In 2021, we have launched the molecular and the POCT products as well. We have recently launched Maglumi X3 equipment with 200 tests per hour throughput and the 20 reagents positions. We have the biochemistry analyzer, Biosys C8 analyzer. We have the Maglumi X8 analyzer with the 600 test per hour throughput and the 45 reagents position. In terms to compete the total lab automation in the market, we have the sole distributor and the authorized distributor of Thermo Fisher for the total lab automation. In total lab automation, we have the different configuration like F model, I model, T model, and the U model. We have a broadest CLIA test menu with over 181 parameters, which can cover the 20 disease panels like infectious disease, thyroid, torch profile, fertility, and many more. This is the Maglumi X8, this is the Maglumi reagents. Our reagents kit are compatible with all Maglumi series. So if you have the Maglumi 800 instrument and you can want to upgrade into the X3 equipment, you don't need to worry about that because our all reagents are compatible with our all instruments. Integrated reagents kits, as Ms. Fatma very good demonstrated earlier. You don't need to prepare the kit, it is ready to use and with RFID. Easy and fast, no pass reagents and loading and unloading. If you want to change the reagents, you don't need to put the instrument on the pass mode or the stop mode. And the same with the samples. We have the 2-point calibration of the master curve. We have the 50 and the 100 tests per pack size of the kit. Choose freely according to your laboratory testing demand. Internal QCs and the calibrators are free of cost with the kits. This is the test menu. We have over 181 parameters with more than 20 disease panels. Snibe makes the continuous efforts to bring the existing regions to the perfection and work on the new assays. These are the assays menu. This is our newly launched Maglumi X3 equipment with compact in size has produced the maximum output of the 200 tests per hour. This is the general specification of the Maglumi X3 equipment. Is the throughput rate of the 200 tests per hour. Cuvettes on board is the 364. This is the 72 samples position. Region positions are 20 and the 181 test parameters and more are coming. So suitable for the small, medium-sized labs or hospitals. This is some functional module of the Maglumi X3 equipment. This is a very good and beautiful, the blue visible cover. This is with the RFID reader, reagents area, and the consumable status bar. You can check the consumable from the status bar. This is the cuvette storage area, solid waste, starter container, and the sample area as well. This is some specification of the Maglumi X3, the highest space efficiency analyzer in the small throughput. It's the same throughput. You can check over there are two different instruments of the Beckman filter and the Abbott. They are producing the same 200 tests per hour throughput, and the Maglumi X3 is the compact with the size. These are the top 10 highlights of the Maglumi X3, one of the highest space efficiency CLIA analyzer to 294 tests per hour throughput with meter scale. One of the broadest CLIA test menu with 181 parameters and 20 more disease panels. This is the continuous to use Maglumi reagents kit with perfect compatibility. High-tech components with excellent performance, user-friendly design, support no-pause reagent, loading and unloading. The whole process for adding reagent only needs 5 seconds. Intelligent washing, different mixing modes, and the washing mode depending on different assays as like as Siemens and as like as Roche. Bidirectional temperature control technology is measuring the chamber to ensure the accuracy and measurement of results. Initiative indicator light make no need to check reagents and the consumable frequently. Intelligent UI. Sorry. intelligent UI interface, user-friendly, easy and convenient operation. We have some different advantages of the Maglumi equipments. We have the various equipment in the CLIA range and the comprehensive test menu over 181 parameters with 20 disease panels. Our reagents are fitted with all Maglumi instruments and the cost efficient because our kits and our calibrator and the control are the part of the kit. Quality guarantee, we believe on the third-party quality control. Our Maglumi series range is also available with the BioRand and the Randox control as well. This is the flash chemiluminescence stability and the sensitivity same as Abbott and Roche, also as Siemens. We have the magnetic microbit separation technology same like Abbott, Roche and Siemens. Automatic easy system test, accuracy and precision 10-point master curve, and advanced component design creates excellent performance. We believe on the external quality control with view certificates. Snibe participate in various CQC programs every year like RICAS, like ICAS and CAB proficiency testing as well. So these are some certificates. The first in China offering in BioRad official IFU to assign the values of the Maglumi CLIA assays. If you are the BioRad user, so you can check the Snibe Maglumi series is also available with the Maglumi name in the BioRad and Randox control as well. And if you are going to be on the CAP proficiency testing, so you don't need to put your results on the other pairs because the Maglumi Snibe pairs is also in the CAP testing as well. This is the difference between the X3 and the previous Maglumi models. The most favorite model of the Pakistan market is Maglumi 800. So in the Maglumi 800 is the 180 tests per hour throughput and the X3 is the 200 tests per hour throughput. And the region position in the Maglumi 800 is the 9 and the Maglumi X3 is the 20 regions positions. The sample position is the Maglumi 800 is 40 and the Maglumi X3 is the 72 samples positions as well. The qubit on board on the Maglumi 800 is the 240 and in the X3 is the 364. This is the excellent witness of our end user. Hong Kong, we have installed the X8, Bahrain, Iraq, India, Nepal and Cambodia. The blue light of the Maglumi X3 and the Maglumi X8 is illuminating the world. Snibe Diagnostic, perfect lab solution for end user, Salman Shehzad. Thank you very much. If someone have any query regarding the Maglumi X3 equipment, so we have available in our display. So we are here for any query. एंड लास्ट पे मैं एक चीज़ अनाउंस करना चाहूँगा कि सीमेंस की तरफ से एक ऑफ़र है, अगर कोई एंड यूज़र या कोई हॉस्पिटल जो है वो इंस्ट्रूमेंट को इंस्टॉल करता है इस प्रेजेंटेशन के 30 डेज़ के अंदर, तो वो अप टू 5 रीजेंट किट जो हैं वो फ्री ऑफ कॉस्ट प्रोवाइड करेंगे. थैंक यू वेरी मच.
Thank you, Mr. Shehzad. He very rapidly gave us an overview of all the products. I guess very rapid. I would like to welcome Dr. Zaruna, my old colleague. Thank you for joining us. At the end of our program, we would like to invite our Chief Guest, Brigadier Abdul Sattar, for his comments. It will be followed by a cake cutting ceremony. So,
Thank you very much. Bismillahirrahmanirrahim. Professor Dr. Amr Ejaz, Dr. Asim, and the senior colleagues. I see various colleagues from the microbiology department as well, because in fact Maglumi has many
number of parameters for the infectious diseases. It is a matter of great honor for me to be here with the excellent people, and I see excellent gathering for learning this Maglumi and other various parameters which are on the Maglumi. In fact, tumor markers, I just say one word. If you remember, about 30 years back, there was a statement that whenever the tumor marker is invented, there is a lot of hope with that, and we say it is a revolution. But when we came to know with further studies that it is also raised in various other conditions associated with that organ, then there is a hope, there is some disappointment. But with further studies, we came to know with some cutoffs which can differentiate from the other diseases which can falsely raise the parameters and with the tumor. Then we have some optimism about that tumor marker. This is to be basically, still today we don't have any ideal marker. But having said that, the number of parameters which are on this instrument, I think so, they will help a great lot in the development, in the diagnosis of these tumor markers. I will not take much time, but I must appreciate Dr. Amar Ejad, his immense contribution to the for the teaching to the young trainees and to the technologists. In fact, Chemical Pathology Society, he made it lively forum for the teaching. For the last, I think, 6 years, he has been teaching on the Zoom very regularly, almost 15 days per week, after 2 weeks every presentation. If I say that our teachers who contributed for the awareness about this society, but making it lively and inviting the people to join this specialty, it is a great job done by Professor Amar Ejad. I really appreciate for them. And then I thank the management of the Maglumi and particularly Mr. Carlos from China, who has also came to Pakistan with the Maglumi. Thank you very much for this. Thank you very much, ladies and gentlemen. And then I thanks all the people for coming here to listen for this. And I also thanks to the management of the Maglumi for arranging such workshops in the Pakistan. I think you are also arranging in various other cities as well. And they will, thank you very much for it.
Thank you, Dr. Abdul Sattar. So I seal the cake, and I would, the cake cutting ceremony should start now. We would like Mr. Carlos would like to do the cake cutting along with Snibe. Yes, okay, so Snibe. Okay, so you want to do the award ceremony beforehand. All right. So we'll start with the award ceremony then. It's heartening to see so many pathologists, technologists, so many people are here that it's wonderful to see.